Thank you. It's great to be here. Thank you, Larry, for inviting me again. Thanks for that first talk. It was fantastic. I'm going to suggest that there might be a variation that you could insert in what you're already doing, not change what you're already doing, that could enhance the effectiveness. You already talked to it, how do you get into the kitchen of somebody. That's one example. You're going to hear towards the end of this meeting, at the end, how you actually, when you double down on behavior and lifestyle, drugless approaches, which I did not learn in medical school, which my residents still don't learn, okay? That in fact you can not only manage chronic disease, you can reverse many of it. And we're told that in guidelines, right? Do lifestyle first, blah, 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 heart disease, diabetes, obesity, etc. And who knows how to do that? The rest of the instructions are about how to manage the drugs, okay? And that's completely reversed as to what we should be doing in those areas. So we need to be able to create simple tools. I like simple. Insert them into high quality primary care in these areas. And if we do that, who knows, we might survive as a profession if we're innovative. So thank you for inviting me. I want to tell you about a network to try to help clinics, primary care clinics, most of whom were family medicine, not all of them, to try to do exactly what I just said. We call this whole person care or integrative care, and the goal was to try to help facilitate and we created a learning community, a network around the country in which they began to implement a set of tools to help them actually insert drugless approaches and lifestyle behavior change into routine practice. Now these were not ChenMed clinics, okay? They had 2,000 patients on a panel. They were very under-resourced, many of them, not all of them, you'll see. And so they were struggling to try to figure out how to do that. Had they been able to reconfigure their teams and their relationships to do this, and though there were several that did have that, then they were able to actually implement it quite easily in those areas and really build on the attempts that they were doing already in those areas. So yesterday we had a half-day workshop with all of them in which they did their final report outs. We started this last year after the last FMEC meeting, ran it through the year, and then at this meeting they did their report outs. They did intermittent report outs, PDSAs and things like that, but then the lessons learned and the discussion behind that. That's recorded if you want to see it. It's 4 hours. It's really fantastic to watch those areas. So I'm going to do a little summary of sort of what that did and what they found and sort of what the next steps are in those areas. Let me just say one thing about relationships as the key to cost savings. We should have a slogan like that. Relationships are the key to cost savings, right? It's very unfortunate that we called it the patient-centered medical home, isn't it? The very first word was wrong, okay? Because as soon as you're a patient, you're in the medical model instead of in a relationship. So we need a relationship-centered care home or something like that, healthcare home. We need to change that model, and that's happening. I'll show you a little bit about that. So this is what I learned from my children and grandchildren. This is a land acknowledgement of where we are, and just want to acknowledge that we are today sitting on the land of the Anasapawi, the Lenape, the Osage, and the Shawnees people, and we acknowledge that this was taken from them. They were displaced here, and that we're grateful that in fact we're able to be here and use it. And also in the area of integrative health, to acknowledge also that much of what goes on and is known in drugless approaches came from traditional practices, such as still go on here and around the world. So here's the problem. You all know this. I won't talk about this much. We're first in spending, double of any other country, 37th by almost any metric that you can do in terms of quality. We're spending more and more money. And there's growing disparity. So all the metrics, all the outcomes in healthcare, if you look at health, are going in the wrong direction. On top of that is the burnout and the dissatisfaction that goes on in terms of almost every quadruple M metric is going in the wrong direction in our country. Okay? Here's a little chart on the right which shows the life expectancy per capita costs in the U.S. is a huge outlier, way over on the right. And the life expectancy we get for that is around Portugal and Czechoslovakia in those areas. COVID has thrown gasoline on that fire. We have lost over a year in life expectancy in 1 year with COVID because the system doesn't actually work to save lives. 3 to 4 times that rate of drop in life expectancy in people of color in those areas. The solution, we already know what it is, okay? If we had universal health care insurance, and a lot of your residents are really fighting for that, right? If we just took universal health care insurance, suddenly everybody had platinum level health care paid for by whoever, would only improve population health by about 15 to 20%. And again, this data is tracked all over the country, and it's known. The reason is because health actually doesn't come from medical care delivery, so it doesn't matter how much you have. It comes from lifestyle and behavior, and it comes from the social and economics. So if we want a healthcare system that actually is part of the solution rather than the problem, we have to get out of this little black area on the top and begin to address the 80% of where health and healing actually come from, which is are these other boxes in those areas. And so the goal of what we're trying to do at the Samueli Foundation, partnering with FMEC, was to try to work to help people do this, okay? To do that, we need different tools. The tools we have built are built for that top box, okay? And especially getting paid for doing what's in that top box, okay? So I was going to ask you about your electronic medical record. You had your own internal data, but did you also have your electronic medical record? Because that was one of the biggest struggles these folks had.
They're all made for people, sir.
Absolutely, you know, and so trying to fit, you know, a square peg into a round hole was a constant challenge that almost all of them had. Some of them did quite innovative stuff around it, though, in those areas. So the tools that we offered to this group are two. One, we call it the Hope Note tools, or the Hope Note Toolkit. That stands for Healing-Oriented Practices and Environments. And we asked everybody to, after they've done the SOAP note, which they have done for their patients multiple times, okay, and structured it, that they actually then do a Hope note. And there's a specific way to do it. There's a form, a very simple form that the patient fills out, asks them, first of all, what matters to them in their life, not what matters to them in their health, okay, what's meaningful for them, and then addresses the underlying determinants of their own healing, and tries to then personalize that and structure that around helping them to accomplish what matters in their life, okay? That's called the Personal Health Inventory. It actually was created in the VA, and then we adapted it to non-VA environments, and that was sort of the entry tool for changing the dialogue and the discussion with the patient. They would then go in and actually have a Hope Note, and there's a guide and a set of questions and a whole set of resources, the first layer of which are free and easy to access so that the clinician can and their team can actually immediately begin to offer those kinds of services, and then a process for linking up to the services that already exist in your community so you can easily bring them in those areas. The goal was to change their mindset around this so that they saw the whole person when they came in. And on the left-hand side is our model of the whole person. It's the physical body, it's the behavioral and lifestyle, it's the social and emotional. You don't have to have a mental illness before you need some support in social and emotional care, right? And it is at the fundamental goal is to understand what matters to them, which is an existential question. It is a mental and a spiritual question. And if you can have that kind of a discussion with the patient, out of that arises an amazing process of healing and discovery that can occur. That's where relationship occurs. So another way, from a systems perspective, set of tools and words that we gave them was something called Integrative Health, and it's the intersection of what I learned in medical school, and you all did too, conventional medicine, evidence-based drugless approaches, it used to be called complementary and alternative medicine, and self-care, behavior, and lifestyle, all done within the context in which they live, the social and economic context. So these were the two tools that we brought to them and said, your job is to actually implement them. Now, these are innovators and early adopters, but the system wants to change. It's trying to change, and so the more we can show models to them, the more this actually can happen to help create an environment in which it can happen more often. This may change really rapidly. COVID has created the language of transformation. And now it's not just a word anymore. The national leaders are actually saying, yes, we need to truly transform our system. And these are two examples. This is the VA healthcare transformation model. I think next week, the National Academy of Medicine will launch a year-long study to see how can we transform the entire VA healthcare system to something that I call the two-circle model, okay? And the two-circle model has evidence-based medicine, what's the matter, over on this side, okay, and the medical services, and it integrates it with what matters to the person. These are the recovery services, these are the healing components that support that, and it's done by creating a personal health plan with a health partner, okay, that's the relationship. Sometimes it's the physician, sometimes it's somebody else on the physician's team. In those areas, and the Integrative Health team puts this together, and it has to be delivered through value-based care, total capitated value-based care, not just, okay, which bundle are you going to get in those areas, okay? This came out of a federal commission. It was published just before the pandemic, and so nobody knows about it. It's called the Cover Commission, and they recommended this, and the VA has picked it up in the National Academy and will now be looking at it in detail in those areas. We already have a report in primary care that says to do that. You all know about this one over here. This is implementing high quality primary care, the first one since 1996, after which nothing happened. Okay, and now there is a real interest and a real movement within the federal government. There's a lot of interest in states and other places to do it, but within the federal government to actually implement this. And so our foundation and many others are now working to try to make sure there's a critical mass and a community support process going on so that they can implement the recommendations. If you haven't read it, go read the recommendations. It was elegantly done. I call it beautiful in simplicity. Okay? First recommendation, the definition, by the way, is whole person care. That's actually in the definition that we're going to talk about here. And the first recommendation is pay teams to help create health, not physicians to do services. Okay, number one. We'll see how that works in those areas. If this works, there will be a major shift in the environment that will allow models like we just heard to actually flourish in those areas. And people won't be so worried about going in and working for places like this. So the overall goal of the Learning Collaborative was this: make integrative health, as I've just defined it, whole person care, routine and regular. Get it into your routine system. We don't want you to build a center over here that provides the services. We want you to do it in your day-to-day practice. And so they were to implement this in a section of their practice, to try it out, and then to evaluate it, do a standard quality improvement PTSA component. Here were the steps that they were given over the year. Understand the crucial role of non-drug and lifestyle approaches. Learn how to use the tools, implement them in your clinic, collect data on that, and then report back on that, and learn from each other. And then report out. And yesterday we had the report out here at FMEC in the workshop in those areas. It didn't cost anything to be part of this, but you had to invest. And so we had an application process, and they had to commit to these things up there. So they had to garner their own internal resources to say they were going to participate and do these things with a team before we would accept them. And so they had to apply that, and everything that came out had to be agreed to be put into a Creative Commons and shared with each other in those areas. So those who passed that muster then also were asked to evaluate, and we gave them some simple evaluation tools so that we could look across the area. The personal health inventory is this VA adapted dialogue. How many of those are they doing? How many hope notes have they done? We asked them to count the number of touches. That's the surrogate for relationships with their patients. How many did they have during that period in the clinic they were implementing it? And then we did, the PHI has some health metrics. Healthy Days is built into it, and some other how is your health on mental, physical, and general areas. But we also asked them to use a validated and standardized simple tool called the Promise 10, which is a NIH-validated tool for assessing well-being and health in those areas. The timeline was this: 3 months of onboarding of the tools and learning those resources. 3 months of execution, and then 3 months of analysis and evaluation. COVID, as you may notice, was right in the middle of the execution. So there was a little bit of a distraction for almost everybody. So we've extended the support network now beyond the year. It's officially ended yesterday, actually, but we've extended it for those that want to continue to have support, because most of them now are only just getting to really run with these things in their clinic because of COVID, and primarily because of COVID and other things that did. We had a great faculty. Okay, here's the physicians, all primary care docs, except for Alan Shaughnessy, who's a quality improvement expert and education expert, and Larry Bauer, who is the grand poobah of innovation, participated. FMEC provided the support and infrastructure in those areas, and these folks then took these clinics and then supported them. We had monthly meetings with the whole group and introduced these things, and then they had meetings in between with the small groups with their faculty members to do this. Lots of other people were involved to support this. FMEC, Denise, you know her, several people from my group were there to support, provide tools, adapt those things in those areas. And all these things are archived and they're free, and we're going to make them somehow available to everybody. Most of it is already available on my website in those areas. So, and then, okay, so here are some of the clinics. You may recognize some of these that were there. I'm not going to read them off, but the only one that wasn't family medicine was this University of Cincinnati internal medicine pediatric residency program. Very interesting. They decided to deliver the HOPE tools in their group visits. They had ongoing group visits, very effective, and so they inserted that. That was an example. Many others did other things in those areas. Jamaica Hospital, we've been working with up in New York already for this, and they got blasted by COVID right in the middle of this. 100 deaths a day during the peak in the middle of the aspect. We had to step back and just do some resiliency support recovery thing for their staff, their faculty and residents after this, and they're still in fact recovering. But because they had these tools up and running, they have now inserted it and are ready to insert this across their entire system. And so we're looking for systems like this to do this next, including in their long COVID clinic that they have now significant. Just something that's interesting, even though this was focused on primary care, I want to point out there were 2 people down here who joined as sort of auditors. This is an oncologist who we are now working with to insert these tools into cancer care, okay, with oncologists through an oncology leadership group. And this is a neurologist who's funded by another foundation called the Bloom Foundation, and they would like to do the same thing. This is not just a primary care issue. Okay, taking care of a whole person means taking care of a whole person, regardless of what medical diagnosis that they have. And so they've asked us, would we develop similar networks in those areas? And so we're exploring adapting some of these tools to do that in those areas. What did I ask them to do? I asked them, number one, if you change your thinking when you see a patient, so you see them as a whole person, especially what matters, spiritual, mental, emotional, and you can touch them on all these levels. That is shifted from a mechanical acute care model over to a chronic ecological care model, and you've done 90% of what needs to be done in those areas. If you can then go beyond that and actually implement in your system a process for actually supporting that component, here's the PHI tools here and the HOPE note leading to self-care behavior. These are the resources that were there. They needed people trained that could help them in this. Health coaching, health navigators. Many of them had those already. Very often they had health navigation because we're trying to get through this complex web of chaos, right? What's called healthcare. But a lot of them didn't have health coaching skills, and this was a key issue, is training them in health coaching so they knew how to support the patient when they saw that that the rice was a problem. Okay, instead of just handing them a list, how do I move them if that's their one thing that we're working on now, so that the behavior change can actually occur? And this is going to be essential, I think, in healthcare going forward. Groups are a wonderful way to do this because guess what? The patients then become the health coaches. All right, they're the ones to actually do this in those areas. Okay. We also asked them to evaluate what they were doing through sort of standard PDSA components and also using the 7S change model and they reported out on those. Also, Alan Shaughnessy brought that in, educated and taught them how to do it, and then evaluated how they were doing that. Okay, so yesterday, here were the 11 sites that were reported out. 11 of the 17 sites, a couple of them dropped out. They thought they had committed the resources and they didn't actually have them. A few of them, most of them, almost all of them, these are, I would say only 2 actually dropped out. But 11 out reported. We only had room actually for 11 yesterday to report out in the workshop. And 1 dropped out because of COVID. They just were so devastated and racked by COVID continually that they just couldn't do any new innovation. It wasn't just ours. It was like, okay, we're just trying to keep our head above water in those areas. But here's some of the sites that reported out yesterday. Okay, so I'll end by just doing a summary of what I heard yesterday. Okay, now this includes a few things that were reported out during the year. And looking at the impact of this. What worked well, there's a list here. All programs actually found that the process improved care and healing. Every single one said this really helped us do better primary care. 5 actually said we're inserting this into our residency program, so we're going to start training all our residents how to do this. 5 actually placed some type of template in their EHR to actually help them deliver this. They found out when they brought their navigators or their coordinators or their health coaches in this that really worked well. It empowered the navigators to do something that they've never asked to do before. It wasn't just checking a box and getting people over to a site. So that really worked well. Patients liked these non-drug services. Nobody had ever actually sat down and talked to them about this before. Okay, you mean you want to know what supplements I'm on? Does that matter? Okay, you want me to actually send you that information? Okay, and what's important in my life? Okay, why do I even want to have healthcare? Staff and navigators, I mentioned that. Burnout. There's a big debate about burnout. Okay, did it make it worse or did it make it better? Some people said, I don't have enough time to do this, and now you're asking me to do another thing, and when they viewed it that way, it made it worse. However, here's a little quote from yesterday. It created a meaningful visit. It brought me back to why I became a physician. And she followed that comment with, and this is helping me with burnout. Okay, so take your pick. Your mindset is a lot of it. Inserting it into group visits, I've already mentioned that. What didn't work well? Well, faculty in these residency programs was difficult to get them involved. The residents actually were out there churning it out, doing these visits. They're in a learning mode anyway, but who are they going to go to teach them to do it? Very few faculty knew how to do whole person care. The EHR, huge problem. Okay, we need an app. That was an over and over quote. Can you give us an app that we can plug into our system and help us do this, that the patient can, answer in those areas. IRBs, those that were doing formal IRB, was a nightmare during COVID. Okay, getting leadership to understand and free up the resources was challenging. Many of them couldn't get their leaders to say, we'll do this. Part of that was COVID, but a lot of it was just not being willing to actually innovate. Having the time, that's really just another name for how it's structured in the resources. Cultivating an interest with many patients who needed it was challenging. I think many of them found that they had to educate, even though patients when they got in it loved it, they had to educate patients about what it was, because it was actually different. You're now talking to me as a person, you're asking what matters, and you want to know what's in my refrigerator, and you want to talk to me about stress and stress management. Wait a minute, I came in for a refill, okay, in those areas. And so there needed to be more education, outreach, and recruitment in those areas. And then COVID took everybody's time and attention around. And I am done. Oh, one of the groups, the Tufts group, there were 2 faculty from Tufts on this, actually created a CMA program. This is what Alan does. That is, he has a training program for medical education there at Tufts. And there is now a free 4-credit CME program that you can get at integrativepain.cme. and there's been over 1,000 people outside of this network that have taken this. So if you're in pain management, which I think has not gone away in the pandemic, right? It's gotten worse. What I heard, it's gotten worse. 90,000 people died last year compared to 60,000 on average from opioid overdose during that. So it's actually got a third worse in those areas. So we need to continue to pay attention to what matters to people. What do we want to do? Well, we want to insert it into groups that are scaling. Okay, we don't want to scale. I work for a nonprofit foundation. We are not a company. We're not interested in being a company. We don't want to be a company, but we would like groups that are interested and are implementing high quality care, whole person care, to just pick up on these tools. We think they're valuable, they're useful, simplify them, put them in, and make it part of routine practice. And so if you have any systems or networks that are interested in doing that, we're all ears and happy to do that. So I think that was it. Thank you. And again, I want to thank everybody that helped out, especially the FMEC folks, the faculty, Larry, and Denise especially were so helpful in this area, and I think they're going to continue to do something on these areas. And of course to the people that, I don't know if they're pioneers anymore. I think they're actually early adopters. I think they're already over in that next wave that Larry showed in those areas. So I'm done. Thank you very much for listening, and I hope that was helpful. I don't know if we have time for
We've got 3 or 4 minutes.
3 or 4 minutes.
A little
Okay.
bit late, so go ahead. 3 or 4 minutes for questions.
Yeah.
Do you have any examples of the help note or an outline on what that
So there is an entire guide on our website with an instruction manual, tools, and resources that go into it, educational videos, etc. on our website. They're all free. Okay, and if you just Google or you just go to my name, drwaynejonas.com/hope.com, shouldn't fool you. We are a nonprofit. Okay, it's all free. You can see the tools that are there, and a lot of the tools were enhanced for this learning collaborative and loaded on. They're currently in a Google Drive for this group because we're continuing to support them. Those will all become free and download. Many of them are available on that site. So yes, and if you're interested, we have a DIY, do-it-yourself component. The neurologist and the oncologist came to us because they just downloaded tools and started doing it there, and then said, hey, can we do more of this in those areas? But we're happy to help and support that, and I have a staff that will help support you that. If you can't find stuff, they'll help you get there and learn about them.
We're going to move right